Yeah, so I'll start the introduction, Doc, and then you proceed from there.
Sure.
So welcome, gentlemen, to our end of November 2022 St. Paul Speaker Series. Today's talk is by Dr. Mukamba, who's painter 1983. He's going to reintroduce himself. He's at UTH in Zambia, and we'll be discussing prostate conditions. So with that said, Doc, take it away. To the participants that are here, they are all from St. Paul's at some point in time, and they can ask questions in between or at the end. It's your preference. So we're going to record this for the brothers who couldn't make it. Maybe they're watching some football or just some usual Friday in Jakarta issues. So Doc, take it away, please.
Thank you very much, Mr. Moderator. It is my honor and privilege, colleagues, friends, cousins, roomies, whatever might apply, to talk to you. I was asked to talk to you about the prostate gland after we had our talk when Nobet and the patients couldn't understand what PSA was all about on a presentation. So I took up the honor after being asked to talk about prostate disease and its conditions. I prefer that I have about 60 or so, 50 to 60 slides to go through. So I prefer that you allow me to quickly go through all of them, jot down any burning questions you might have, but then we can discuss freely at the end of it all. If you still can't conclude, you can still inbox me and we can have a chat. I also hope that the moderator will allow me after the presentation to immediately post the PowerPoint presentation on the blog so that those who might need to go through it may go through it. I have presented this discussion in a very simplistic manner, one that doesn't require memory because I'm not very good at memorizing myself, but I hope it will be comprehensive and to help us understand what I'm talking about or what our prostate is all about. I've entitled our discussion today, Understanding the Prostate Gland and its Conditions. Next slide, please. I will not necessarily go as written. I might glance through certain slides because of time. But however, I laid out our presentation in 7 different components. Introduction, there'll be an introduction. Basically, this will be talking about the anatomy and structure of the prostate and its function, because it is only when we understand these two that we understand the symptomatology or the disease processes that arise from any derailment in function or anatomy of the gland itself. After that, we will follow it with the conditions itself that affect it. There'll be a slide next on the symptomatology. Next slide, next slide. There'll be a slide on the symptomatology. There'll be a slide on summaries, by the way, on the tests that we do next. There'll be a slide on the different, next please. The different treatments we offer for these conditions. And then at the end of it all, I'll just recoup on what I've spoken, and which is what I've entitled Prostate at a Glance. And then I have also added some helpful information, which I will not go through because there are various videos on various different approaches to the prostate through natural foodstuffs, through alternative remedies that might prove helpful to us. May we proceed now? Next slide, please. Next. Next. First, I thought I should take time to introduce the presenter and cover myself in case of from litigation, in case I mislead anyone. Dr. Mukamba is a clinical imaging specialist at consultant level in nuclear medicine at the University Teaching Hospital. He is currently the head of Department of Radiology in the UTS Children's Hospital. He is a pioneer and founder of modern clinical nuclear medicine in Zambia. He carries with him 32 years experience, which he has worked both in the private and the public sector. He is not, I must emphasize this, I am not a urologist. Prostate disease is a preserve of the urologist. However, I have sufficient information to help us understand what the anomalies that arise from the prostate that are based on my personal experience and research. I am also Penta 82. Sorry, to just remember the moderator said I was Penta 83. I'm actually Penta 82. Proceed, please. I believe.
Doc, just one question.
Yes, please.
I got a chat message from Big C that you couldn't see the slides. I don't know if everybody else can see the slides.
I can see them.
I can see them.
I can see the slides, all right.
So maybe Vatsala, your connection wasn't good, but I think the slides are available now. Yeah, the doc, you may continue. I'm sorry about that.
Okay, sure, no problem. Further, I want to, I just in my introduction, further say that I, one of those people who believes in a holistic approach to treatment of diseases. I believe that food, organic food, is good and helpful in sustenance of a human body. It is the first #1 treatment for any ailment we have in the body. If it maintains normality, and therefore if you retain normal health state, chances that you might fall sick are reduced. Secondly, I also believe that the human organism is made of the physical body, the spirit, and the soul. So in approaching any ailment that the human body organism might have, I always look at it from those lines of aspect, those 3 areas of aspect: the physical body, the spiritual needs, and the soul wellness of the body. To emphasize that, I myself have gone ahead to register 3 vehicles of business in which I conduct this. Avant2, which is what is highlighted there, is basically to do with farming and organic production of organic foodstuffs and herbs. Healing Hands deals with the spiritual needs, and Herb World Healthcare, it deals with natural herbs and alternative remedies, but I have combined it with the science of medicine. So it's an integrative medicine specialist a vehicle of doing this. Next slide. The prostate. What is the prostate gland? It is part of the male reproductive system. It is an accessory gland. I'm sure those who still remember our biology, even if we didn't proceed to do it at the tertiary level. The prostate is an accessory gland and also a valve that helps with urination and ejaculation. It is a small gland that sits at the bottom of the prostate. I think maybe we can move to the next slide. Prostate, it sits at the base of, yes, so to understand what I'm trying to say. From the structure there, you can see that the prostate is that orange beige like structure clearly labeled at the base of the bladder. The testicles from them, which empty into the which all congregate into one tubule called the vas deferens and comes to join the journey to the urethra, which is the male member or the penis, which is the final pathway. But in between there, we have another gland called the seminal vesicle, which produces about 65% of seminal fluid after the sperm is produced from the testicles and the sperm goes through the vas deferens, and when they reach the seminal vesicles, this produces some fluid, which is in volume it's about 50 to 65% added to the secretion to help with the progression of the sperm down the channel. The prostate also contributes another 20 to 35% of that fluid. And the testicles therefore only produces roughly about 5% of the fluid. Next slide. I just want to show you the intimate relationship. Of course, the bladder sits behind her. Now, what I wanted to show you is the inside of the gland with this slide. If you look carefully, when the vas deferens comes into and enters the prostate gland, and the seminal vesicle also produces a duct where it secretes its fluid. When the vas deferens miss a seminal vesicle duct, together they come out into what is called an ejaculatory duct. And the prostate also then adds to its secretions at this level. And finally, they get into the urethra, which arises from the base of the bladder, passes through the prostate gland itself, out into the urethra, and the eventually out for ejaculation. It's important that you remember this intricate structure at seconds, because in the function, this will be, you understand it when you see this, yes, that. Next slide. The prostate itself, in itself, is like the size of a ping pong ball. It weighs roughly about 30 grams, and it is for a good comparison, it's like an onion. There's the outer layer of onion skin, the skin that comes out. In this case, the skin is what we refer to as the capsule of the prostate. It is usually smooth and made of connective tissue and rubbery. After that, the inner layers of the onion itself now are divided into 4 different zones. Next slide. We have the next slide, please. Yes, okay. Anatomy, we have the anterior zone, we have a peripheral zone, we have a transitional zone. Next slide. And we have a central zone. The most important aspect that we should worry about that causes symptoms is the transitional zone, because this is the part of the prostate that continues to grow throughout life. And it is a part of the zone that surrounds the urethra per se. Next slide. And this is what this slide is trying to show. So basically, you can see the transitional zone is the yellow aspect, and that's a bit that surrounds the urethra per se. And it is right at the top. It covers most of the area above the point where the ejaculatory duct enters. Why that is important to note, as the prostate contracts to secrete fluid, that transitional zone fills off the upper segment of the urethra. So the contents of the bladder therefore do not come out. So there's no urine that flows out of the bladder at that point. In other words, you cannot have ejaculation normally and urination at the same time. That's the valvular function of the prostate. Next slide. Functions, to simplify them again, I further subdivided them into 3 categories. Those, next slide, those that are sexual. Next slide. Those that are sexual, those that are valvular, and those that are hormonal. So the main purpose of the prostate gland is naturally to produce, is sexual, to produce fluid that adds to the sperm and protects the sperm. It has this prostatic fluid in itself contains enzymes, zinc, very important. Zinc is a very important aspect of fertility. And in addition, we have, it has a protective media that keeps the sperm cells alive. It is slightly acidic in itself, but the remaining 65% of the fluid is alkaline. So it turns out the overall content of the semen, of the fluid, is therefore alkaline. That alkalinity in itself helps counter the acidic environment in the vagina that would kill the sperm. Amongst the enzymes that the prostate produces is one so-called prostate-specific antigen, which has been associated with the increase with disease patterns of the prostate, and is what we use to measure degree of disease. Next slide. So I think I've already alluded. Next slide. I've said this already. Next slide. Now coming back to the muscular valvular function, I did allude to it earlier on. Basically, as the transitional zone contracts, as the prostate is producing secretions, it seals up that upper bit. So that therefore becomes a valve. You can't open both channels at the same time. Next slide. Next slide, please. The hormonal function is that of the prostate to grow well requires androgens. The main androgenic secretion we have in the male is testosterone naturally. However, testosterone in itself is not active, is not in active form. It requires an enzyme that the prostate produces called 5-alpha reductase to convert testosterone into a biologically active form called dihydrotestosterone or DHS. This is important because it not only helps the prostate develop as you grow, but it is also the main component that leads to. Hello, can you hear me?
Yes, we
Hello?
can.
Oh,
Yes,
okay.
we can. We are following.
Okay, all right. That leads to secondary sexual development changes that we get as men. Next slide. So abnormality in either the structure or the function is the resultant of disease processes of the prostate. And again, because I knew Raymond has even forgotten his job title, I simplified it for him. Again, if you notice, I keep referring to 3. Disease processes are 3 categories. Next slide, there's inflammation, there's the prostatic enlargement, which is subdivided into 2. Benign, which means non-cancerous growth of the prostate, which tends to be global. It's called benign prostatic enlargement or benign prostatic atrophy, and in some cases prostatic hyperplasia. Then there's focal or localized enlargement of the prostate gland, which usually tends to be malignant, and that is what we call prostate cancer. Next slide. Next, please. Inflammation is usually found, basically inflammation can be either infective, which is common in our part of the world, or non-infective. And it is the commonest cause of prostatic disease in males under the age of 50. This can be either acute or chronic. This refers to just time frame. Anything below, acute is usually 2 weeks medically, but in the prostate, they have a cutoff point of three months. So anything that is acute, commonly, the first thing we think of is as a result of pathogens, and the commonest being bacterial. Bacterial infection can lead to either just simple infection, sometimes can lead to an abscess in the prostate, and will therefore quickly respond to antibiotic cover. Next slide, if it is non-infective and the inflammation goes on, can be, now it will be non-infective inflammation. It will usually take 3 months or so, or is referred to as chronic prostatitis or chronic pelvic pain syndrome. And in this case, next slide, in this case, we give pain relief or relaxants to help relax the soft muscle of the urethra to alleviate the suffering. Benign enlargement, as I said, is the most common condition above the age of 50, going to somewhere around mid-60s. And like I said, this is non-cancerous, and the culprit is the transitional part or transitional zone of the urethra, which grows. As it grows, it presses the weakest point in the prostate, is therefore the urethra, which is a potential space. So it will grow into that space, and depending on how fast it grows and where it grows, it will cause narrowing of the urethra and lead to emptying problems or urination problems that are associated with the prostate. Sometimes it can completely block that pathway, and the bladder balloons out and cause acute retention of urine, going to the far extreme. But as urine is also trapped, there's a tendency to reflux. So it will flow back into the ureters and into the kidneys, leading to recurrent urinary infections. It can also lead to stasis of urine, leading to bladder stones, and subsequently kidney failure. Next slide. Next slide, please. Next slide, yes. Coming to malignant disease. Like I said, this tends to be focal. It tends to be irregular. It is hard. Remember, the prostate is rubbery. It will tend to be hard and focal. And it is believed to be only second to skin cancer in the USA. In Zambia, however, it is the most common form of cancer in males. And it has risk factors. It is important we know these risk factors. Basically, again, like I said, to simplify it, there are 3 main positive risk factors associated with prostate cancer. By the way, all men are at risk of prostate cancer. Because I remember one time when we were talking about having ourselves tested, I felt some people thought they do not need to test for some reason or another. Even when the age, at the age of, when the average age of over 50.
You will remove the song there, but you're about to mention my name. Don't go there.
No, sir. I'm afraid of the kuta. So at that point, age, really, once you reach the age of 40 and above, I recommend that you should have yourself tested, because you'll notice that amongst the risk factors of cancer is age. Naturally, they'll say the older you grow, the more you're at risk, and the age of mid-60s is where the disease, yeah. However, next slide, as we go to the next factor, you see that the next thing is ethnicity. Being an African or Negroid per se, are more likely to get prostate cancer than other races. It also follows families. In a family where there's a positive history of prostate cancer, please be on the lookout. You're at risk of getting cancer. And some associations, if you have a relative first degree who has had prostate cancer, be on the lookout. If you have had cancer diagnosed even before you were 55, and you think it was eradicated by some treatment or some sort, it is still good to follow up, because secondaries, or what we call metastases, sometimes get embedded in the system. So you do not stop screening yourself for that. Next slide. Also, that certain cancers noticed, for instance, in certain families, to do with the breast, the ovary, and the pancreas. If you have a relative who has one of these cancers, by the way, breast cancer can be found even in men. In fact, it is more aggressive in men than in women. That is also a risk factor. The one negative risk factor, which is a relief sigh for most of us men, is that benign prostatic disease does not predispose you to cancer. I know that most of us, as we grow, will have benign prostatic disease. But the good thing about this finding is that it doesn't mean all of us will have prostatic cancer, though. But since you don't know whether you have one or not, you keep screening yourself. Next slide. Next slide. We now come to symptomatology. Again, to simplify it, symptoms according to the dysfunction or the symptom functions of the prostate, I divided the symptoms according to those anomalies in those different functions. There will be valvular dysfunction, symptoms associated with valvular dysfunction. There will be those associated with sexual dysfunction and those associated with hormonal dysfunction. However, remember, sexual and hormonal are interlinked, are related, because one hormone leads to increased activity. So that we find that they tend to have complying symptoms or common factors, symptoms there. Then the fourth, which is not per se a prostatic disease symptom, are constitutional, what we call constitutional symptoms. If you have an infection, for instance, you will have fever, you will have pain, you have discomfort in the abdomen. Those are the symptoms that are associated on that fourth category, the general symptoms, which are not per se unique to the prostate. Next slide, please. The valvular symptoms, next slide. The valvular symptoms I alluded to. Next slide. There are those associated with pressure on the urethra and causing problems with flow or outflow of urine from the bladder. So you either have little urine flowing through, or you have difficulties initiating urine, or you can't stop dribbling. Even after you finish urinating, you find that there's always something that's left in your underwear, or you can just have a completely weak flow altogether. Next slide. Complications, of course, of compression and hold up of urine, which I already said earlier on when I was talking about the pathophysiology of this, that if you have stasis of urine for a long time, you get recurrent urinary infections. Recurrent urinary infections in men is not a common disease entity. When you find it that keeps recurring, look out for or search for something. In elderly men, usually it points to the prostate. The next category that are affected by recurrent are the children, and they are usually associated with posterior urethral valves. In other words, there's a congenital anomaly where they develop valves at the base of the urethra. What results is recurrent urinary infections. Recurrent urinary infections lead to all sorts of complications: infection in the bladder, infection in the kidneys, which eventually leads to failure, and of course, stasis of urine with all those chemical products that are kept there leads to stone formation as well. Next slide. Now we come to sexual dysfunction. Basically, sexual and hormonal dysfunction, though the cause is different, the effect is the same. You will have pain on ejaculation if there's inflammation, for instance. You will have pain along the pathway of the urethra and the ducts that produce sperm and this fluid, that is in the penis, in the scrotum area, in the scrotal area, or the area between the scrotum and the anal area and the base of the penis, which is called the perineum. If there's too much inflammation and you invade the blood vessel, you may get blood in sperm. The cancer has eroded the duct, the blood in sperm. Complications, of course, have to do with sexual function, which are also, these are also associated to be with the symptoms of hormonal dysfunction, erectile dysfunction, of which we found the solutions to these in the name of certain blue tablets that I know Raymond likes. However, it doesn't necessarily mean, next slide, it doesn't necessarily mean that it will entirely deal with the problem. Sometimes all you need is to address the prostate problem and you are back to normal. With erectile dysfunction, of course, and the result. Next slide. Like I said, complications of the functions. The other symptoms associated with it, alluded to the beginning, are constitutional symptoms. Whenever you will have fever, chills, body aches, and pain. Next slide. Now, how do we investigate prostate disease? There are basically 5 things we do. First is that you take a history and you examine the patient. And the most important examination is a rectal examination. Then, next easiest one that we can all do is to assess blood for your prostate-specific antigen levels. You want your levels to be below, I think it is 4. It should be 4 nanograms per deciliter or below, if I'm not mistaken. You want to do ultrasound. Ultrasound basically will give us an image of the contour, shape, and outline of the prostate. It is good, it is helpful mainly in detecting focal growth over global growth. Focal growth will point us to cancer, but does not mean it is cancer. If we find the focal growth, I do an ultrasound on you, then I want to do that. The biopsy is basically where you get a small tissue of that abnormal tissue and take it for histology to diagnose cancer. Then finally, we have MRI, which I think everyone has come to know now. Again, it is more specific anatomical imaging of the prostate gland and the pelvis, and helps in staging of the disease. Next slide. Next slide. Digital rectal examination, for those of us that have had the misfortune or discomfort of having it, is basically where a doctor sticks his fingers into the rectum. If you remember the anatomy, the rectum is just behind or posterior to the prostate gland. So therefore that offers a window to access the prostate for examination. What you do is just ask the patient to come when you're having it done, the patient preferably should have an empty rectum so that you can stick in your fingers with gloves, of course, and project your fingers anteriorly or towards the front at the base of the bladder, and you feel the prostate. A normal prostate will be rubbery in outline. And having a rubbery feel and smooth feel of the prostate does not exclude prostate cancer. Remember, when you're coming for an examination, we are not so worried, as clinicians, we're not so worried that you might have benign hypertrophy, because at least that is we are worried about finding cancer, which will kill you, and quickly addressing it. If you have an infection or inflammation, there will be tenderness when examining the prostate as well, but it will be smooth and rounded, rubbery instead. Only that when you touch it, there'll be tenderness, especially if you have an abscess, you find someone who even wince or cry out. The prostate produces the enzyme, prostate-specific antigen, like I said, so we use that as a measure also to test whether you have prostatic disease or not, if it goes above a specific level. Next slide. Ultrasound, I spoke about it. There are two ways of approaching ultrasound. We can get a rectal probe with the lubricants, stick it through the rectum, and that is actually that's the best way of accessing the prostate, because you get closer to the gland and analyze it and study it throughout. It will give you, it is better than the finger in the sense that it will make you be able to go through the various layers of the onion, like I was saying. And if you find something that is local and suspicious, normally when you're doing the ultrasound, you have a probe associated with it, which you send in, and ultrasound helps you target either through a needle or some gadget that cuts out small pieces of tissue from that point. So what you do is that ultrasound is guiding you to where there's an abnormal focus, and it's the abnormal tissue that you're interested in. So therefore, you target in with a white bone needle or a resection probe and get some tissue and come out with it, and for histological examination. And that's what leads us to the next investigation, which is the biopsy. Next slide. Oh, ultrasound, by the way, can be done through commonly, because of the inconvenience of doing rectal examination, the rectal probe tend to be expensive. Do not be surprised if you come across somebody who does ultrasound transabdominally, in other words, from the front through the abdomen. With a full bladder, you can still locate the prostate and look at it. But it is more sensitive using a rectal probe. So if you find yourself being examined through the abdomen, do not query the doctor or the technician. It can be done that way. Actually, commonly it's even done that way. Next slide. Magnetic resonance imaging. Next, you went back, move. Yeah, sorry, where? Okay, next. Yes, basically MRI, most people know CT. CT, basically, using magnetic wave, it is safer and less destructive. Remember the prostate. Sorry, someone's speaker is on. Hello? There's someone whose speaker is on. Okay.
I muted them.
Okay, thank you. When it comes to magnetic resonance image, it's like CT. The only advantage is that CT uses X-ray, which is destructive. Remember the prostate, the gonads or the testicles are within close vicinity, and they're very sensitive tissue. We want to keep you more, productive to produce normal sperm or to reproduce. But even if you don't reproduce, you still want to know that when you indulge in social activities, even if it's for pleasure, you only feel that you're a man if you produce an ejaculate active. So we would recommend CT for prostatic examination. We will recommend MRI for that. What MRI does, it gives us the global picture of the pelvis. The prostate, it highlights and identifies the prostate in itself and shows us the anatomy, the normal anatomy to demonstrate the capsule, the various zones of the prostate. But in addition, it will also gives with quick ease, it also gives us an environmental picture of the whole pelvic cavity and the bony structures, including the backbone, because prostate cancer is notorious for spreading to the lumbar spine or the backbone quickly. In fact, before you know it, most people will come complaining of back pain. Then we discover, when you find out, you find that already to the backbone. Next slide, please. We come now to the treatment modalities we have. Again, I divided them according
Sorry, Doc, I have a question.
Can we have the question at the end, or it's very burning, you need to have it asked right away?
No, I can ask at the end, just that the moderator asks, I said we can ask whenever we need to. But okay, I'll wait until the end.
No, I actually stated that I'd prefer that we did it at the end. All right, then come to treatment. Treatment will be according to the 3 categories of pathology. Again, next slide. Next slide. When it comes to inflammation, I already spoke. Next slide. I already spoke that commonly this is because of bacterial infection, so antibiotics is what we give. When it comes to non-infective prostatitis or inflammation, it's normally a matter of killing pain and relaxing the smooth muscles of the urethra, so then you can we can let out urine go through. Some people become so painful, so uncomfortable, you might even need to give low grades of anxiolytics to reduce anxiety, or some people even go to the point of depression. So we give mild antidepressive drugs just to help relax that, because it can be very uncomfortable. You're in the presence of company, suddenly you feel yourself dribbling, and the scent of urine in public is not a very pleasant thing. Next slide. Occasionally, the other modalities that are used, remember, because this is an academic discussion, I decided to be all inclusive. But sometimes we are, so per se, normally you will not go to such extremes. But anyway, for completion of the discussion, you have physical therapy, psychotherapy. Remember, I was talking about anxiolytics, and it can be depressing to you. So if you find that depression is a factor that is affecting you a lot, we will send you to a psychiatrist or psychologist to help with that. If you have unbearable pain, we have probes through physiotherapy. They'll send electrical stimulation that massages the gland for you, including nerve regulation to that area. Rarely, very rarely, in very extreme cases, do you use surgery, as in global removal of the prostate to address inflammation. However, surgery has a role where you have an abscess. You need to drain the abscess. Surgery is the way to remove that pus. And of course, there are always a combination of therapies for completion of the discussion, academic completion. Next slide. Benign enlargement of the prostate, categorically divided into 3 categories. Again, the approach is through medication, through some procedures that go and resect out small components of the tissue to open the pathway, and surgery. Next, let's go into more detail. Next slide. I don't know if my friend, Evangelist Leonard, is listening. This is when he confessed to be a true evangelist. It was through these drugs they give that basically relax. This particular drug called tamusolocin, which is just basically a receptor that relaxes the tone of the muscles so that urine can pass through and you do not get the symptomatology that's associated with it. So it is not really a treatment, it is a way of avoiding the complication and once the process goes through. I would like to think treatment is something that tries to stop the process from advancing. Next. Invasive procedures are done where you insert a probe through the urethra from the male member, and when you reach the level of at the base of the bladder, you'll find that it's endoscopic. So as you are going through, you can see the urethra and the diameter. Then you find that it begins to narrow as you are reaching the prostate. So you know that, okay, this is where the point of obstruction is. And with the probes that are inside there, you resect the tissue out. In other words, to simplify it, wazembulula around the urethra, so the urethra opens up away and urine can come through. The principle is the same. People have used other techniques where they use isotope materials that irradiate the area locally without going too much depth to kill the surrounding transitional urethra, prostatic tissue. Again, the aim is trying to open the pathway so that urine can pass through. Newer technology involves heat or using microwave thermotherapy. Next slide. Surgery is what we used to know in the beginning. If you have prostate and you find that it is causing a lot of things previously, it would be you just go inside, remove part of the prostate or remove it in totality, depending on what was done. But as we've made advances in medicine, you try to be as conservative as possible. That's how the minimal invasive procedures came up into being. Next slide. Now comes to the issue of cancer. Treatment of cancer is definitely dependent on how advanced the disease process is. So therefore, when we discover that or we suspect to have cancer, after we've done the digital rectal examination, we find a suspicious hard foci. Ultrasound shows that there's something, we take a biopsy. That's it. We don't need to wait for histological examination. We immediately ask for a bone scan, isotope bone scan, to look for metastasis in the backbone, the lumbar spine, and we do MRI. We are looking for diseases. What we would like to do at this point, we want to categorize the disease into two categories. Disease that's confined to the prostate or localized to the prostate, and disease that's beyond the prostate. The boundary that we use to determine this is the capsule. So if the capsule of the prostate, if we remember from the onion description I gave, that outer reddish or brownish there, the capsule is intact all around, then most likely that disease is still confined to the prostate. The disease can spread in micro seedings through bloodstream as well, but it means the bulk of the disease is still confined to the prostate. We're happy to find the disease at that level, because then the treatment is just removal of the whole prostate. Because there's still a little risk that some could have spread through blood supply or direct transfer, we have not just detected it, we still go ahead and do radiotherapy. Radiotherapy is, to simplify it, is when you use X-ray tissue to bend surrounding tissue. It's not X-ray that we use though. We use X-ray to surround tissue, surrounding tissue that will kill off any adjacent cells that might have received seeding of the cancer. Brachytherapy is where you insert isotopes in small quantities, so that you set them there, they stay there, and is less destructive than radiotherapy, but achieving the same purpose. Next slide. When the disease is beyond the capsule, the prostate, now it has already spread. It is in the prostate. If we find the disease in the commonly to present with the painful backbone, and we find the secondaries or seedings in the prostate in the back, what we do there, nuclear medicine comes in. We give isotopes. First of all, you do a nuclear medicine scanner to diagnose it and to show you how far the disease is. You use that as a baseline. After 2 weeks or so, you order another isotope that has a destructive nature. Because cancer cells have a greater appetite, have increased metabolism, which is the same principle we use for diagnosing it. When you give this metabolite, usually we use the phosphosphonate, which is bone tissues made of phosphate. It will absorb it aggressively. Because this cancer is aggressive, it will take out the bulk of it. We use that knowledge of the cancer cells to inject an isotope now that destroys tissue. Usually beta or alpha rays containing properties that travel for a short distance, but they're destructive. So because the cancer cells are greedy, they'll take up 90 to 95% of these cells. And as it decays in those tissue foci where it is allocated, it kills off the cancer cells. That reduces the pain on the bone tissue. So basically that's to do with the bone metastasis. Coming back to the prostate itself now, remember the prostate grows with activation of androgens. So in this case, we do not want you to have testosterone, high testosterone levels, which can be activated because the faster it grows, the more you have tissue to grow the cancer and spread out. So what you do now is you kill off testosterone supply to the cancer. The easiest way to do that is castration or orchidectomy, which is surgical removal of testicles. Believe you me, most men, no matter how old they are, even in their 70s, usually have a challenge to that. They tend to feel that they're no longer men if you remove their gonads, even if they're not functional or a cause of disease to them. So normally if you approach that way, most men will refuse that treatment. So what we do, we have chemical castration. It takes more drugs and of course the more side effects, but sometimes that's the only way we do it. And we use, that's where the role of gonadotrophin releasing hormone analogs are used. So what you do, you block those receptors that produce testosterone and then the testicles. The chemotherapy, similar to test, you want to kill surrounding tissue or cells that have been circulating in blood supply that spread into other tissues, and kill them, and that you give through chemotherapy. It has the side effects, but unfortunately, it is not because chemotherapy has accompanying symptomatology of loss of hair because it kills both normal cells and abnormal cells. So abnormal cancerous cells have higher appetite and greed for anything that does their metabolism, so they'll take up more and you kill the radiotherapy. In this case, it is can be used to associate it with the local killing of tissue in the body. You use radiotherapy to kill metastasis, but in practice now with medicine, medicine to next slide. Next slide, please. Other treatments. One option, now this is where it sometimes comes, if someone comes to you that's so advanced in disease, that's literally dilapidated, the disease is so advanced that if you give chemotherapy or any, you actually reach it faster. Sometimes choose to seek touch. Now choose not to give any treatment to those people. And you assess them. If you think that will psychologically affect them, you give placebo drugs, you give vitamins or something just to play on their mind. But you know that if I give treatment, this will take their life even faster than not. So what you do, you prepare them psychologically, you tell them how advanced the disease is, tell them what the prognosis is, and basically you ask them to prepare for what is inevitable. I to bone metastasis. Next slide. Now, next slide, to just recoup on what I've just said. We remember the prostate and associated structures, and the rectum. Again, like I was saying, you see the rectum is quite close to the prostate, so you can push in a probe there with your fingers to access the rectum, the prostate. And the other window of even looking through accessing the prostate is through the abdomen, through the bladder when it's full. But there's bowel and there's a lot of interference that way. Next slide. Like I said, the prostate is an accessory gland that sits at the base of the bladder, through which the urethra permeates on its passage out to the male member for urination. The part of the urethra that passes through the prostate is actually membranous. So it easily collapses and everything. And it is susceptible to trauma. So the prostate actually has also plays a protective function on that part of the urethra. The prostate has a secretory function, which is its main role as an accessory sexual reproductive gland, which helps protect prostate and aids in the process of ejaculation. It also helps in the control of urination. Next slide. Disease conditions are basically three: inflammation, enlargement, which is divided into two: global enlargement, which is called benign prostatic enlargement, and there's focal enlargement, which is normally tends to be cancerous. Next slide. How do we test? Through examination, digital rectal examination. We test blood for prostate-specific antigen. Next, we have ultrasound of the prostate, which can be done through the rectum or through the abdomen. We have biopsy, which helps diagnose cancer, where we now suspect there's cancer. We only take a biopsy when you suspect cancer. Cancerous focus, by the way. And then MRI, which is important in the staging of disease. I mentioned a bone scan here. Bone scan is also an important tool because commonly it spreads to the backbone, but it is not ideally, it is not specific to, bone scan is not specific to prostatic disease alone. That's why it's not part of the, but it helps a role in the staging of the disease process also. Next slide. Treatments, inflammation, like I said, antibiotics, and painkillers, and we relax, smooth muscle relaxants to help with urination, and occasionally surgery in extremes. Next slide. With benign disease, again, we have drugs that help relax and the smooth method to increase urine flow and avoid complications. If it is global enlargement of the prostate and it's really hindering the prostate surgery, where we can remove it depends on how you assess it and what your treatment option is. You can either remove the whole prostate at once, or you can partly remove it. Next slide. Next slide. Cancer, like I said, you want to find out whether the disease is localized to the prostate or it is beyond the prostate. If it is localized to the prostate, we're happy. We just remove the whole prostate and now attacked possible surrounding seedings that microscopy that might have been missed through radiotherapy or isotopes that you localize there. And next slide. And if the disease process is beyond the capsule or beyond the prostate, now castration is the first thing you want to do. That can be chemical or surgical. And then you deal with the secondaries that might arise to reduce pain effect of that. You do give chemotherapy to kill any circulating seeds that might be not even localized to the pelvis alone. And you want to attack all of them so that once you treat somebody and you're successful, you don't want them to have a recurrence. However, you cannot completely, the life is such that there's never an all or none situation with cancer. There's the option of where you wait and see in persons with disease that is terribly advanced. Next slide.
I'm on the conference call, tell me more.
And in conclusion, the prostate is a small muscular gland that helps with reproduction. It produces fluids that help transport and maintain safety of sperm. A normal functioning prostate, it should be noted, is not critical for one's continued existence. However, it is essential for reproduction. A person with a prostate problem is best quickly seeks attention of a doctor for various recommended treatment. Without seeing a doctor, I can now, as your doctor now, I can recommend that if you're at the age of 40 and above, make it a habit at least to have a PSA, prostate specific antigen blood test done annually. I currently do it twice a year. This year has been bad for me with a few other complications that came up with my bones and all those things. So I became a bit thorough. I have had it done 4 times already. But at least if you're approaching the 50s, I would recommend you do it twice a year. At least you do the prostate specific antigen twice a year. Do prostate ultrasound at least once a year. And those will guide you whether you need further assessment or not. So you can do that even before you see a clinician. And if you begin to notice symptoms, frequent urination, usually it is at night that people notice it. Sometimes it is not necessarily the prostate. It can be maybe sugar disease, but commonly it is because we like going to the local watering well and take a lot of alcohol, which is a diuretic. And you find yourself frequently going to empty. However, that alone, if its flow is nice and normal, does not point to prostatic disease. It is when you start having a weak flow, you're stressing to urinate, you are dribbling even after you think you've stopped, or you never stop, or you have a very weak flow, then that should point you to prostatic disease and have yourself tested. If you have recurrent urinary infections in a man, that usually a man in the 4th generation and above, that usually will point to prostatic disease. Please have yourself tested. Next slide, if there's anything. Yes, there is. What I've done with this slide is basically, I've given you a link to various slides and video shows, I think about 8 to 10, talking about alternative remedies, foodstuffs to take and consume to help reduce prostatic growth, to help some say it helps even when cancer is found, it helps limit symptomatology and everything. You'll find this. I'll not go through this. I'll leave it for you to go through in your own time. I think we've now come to next slide, to the end of our presentation. And I will take questions now. Thank you very much for listening to me.
Thank you so much, Doc. So we had the hand raised by Jason earlier. Do you want me to keep the slides up, or should I take the slides down?
Okay, keep them up in case they need to refer to them.
Okay. Okay, Shuko, go ahead, please.
Good afternoon, Doc. This is Jason. I'm Penta 86. Just one question. I may have missed it, but it's on the 5 methods to detect a prostate problem. My question is, which is the most effective? Because I wasn't sure whether you have to go through all 5, or the medical practitioner can just use one and say, look, I've arrived at a conclusion.
Okay.
To be honest, the one of digital rectal exam does not sound very appealing to me.
I know, not even to your doctor. but I'll tell you, to answer you the question, you do not determine the way to investigate yourself if you're a non-clinician. You see, if you suspect you have a prostate disease, you go and see a clinician, preferably a urologist. Why? Because he has the background knowledge of all these things. But the first thing we do in medicine is to take the history. It is part of the investigation. When you tell me the symptomatology you give me, you direct me to your prostate, that have a prostate problem. Then, whether you like it, if I'm thorough, if I'm a good doctor, and I miss a digital examination, suspect me. So as much as you don't like it, that's the next thing to do. But however, what you can do before even seeing the doctor, you can probably go to a lab test, a laboratory, and that's for a PSA level. And you can probably even go to a center and do an ultrasound. That said and done, those negative findings per se do not exclude prostatic disease. It's a picture that combines history, examination, and the level at which you conduct the test, or the first 2 or 3, inevitably you have to do them. You have to do a digital examination. You have to do, because remember, sometimes symptoms can mimic prostatic disease when it's not actually prostatic. It could be a mass or an inflammatory mass sitting next to the prostate and has infiltrated or started putting pressure on the prostate. So the prostate starts giving symptoms, and that is completely unrelated to the prostate. If you just remove that mass, your prostate is well and good, you're back to normal. So it is important that you see a clinician, a doctor, examines you, takes a history, examines you, and as much as you do not like the uncomfortable examination, he has to do a digital rectal examination to assess your prostate and assess his health. Then the next thing he'll do, he'll accept if you have already come with the PSA levels, he'll recommend that. So if you're clever, do the PSA and ultrasound in advance. As you're going to see him for his digital examination, you have got that information already. Then he decides whether he's going to go ahead and do a biopsy and subsequent MRI. The best thing to do is that if you want to be, if you have no symptoms, if you're not getting any of the symptoms that seem to be pointing to prostate, routinely every year, our group, at least the group on this blog we're on, should all have a prostate-specific antigen test annually, at least once. I would recommend twice a year. And should also have at least ultrasound once. I hope I've answered that question. There's no going around the digital examination.
So you can't escape. No, noted. Noted.
If you find one who's making you avoid it, go and seek a second opinion. I advise.
That's a good answer, Doc. There's another question from Mr. Petten. But Doc, as you talk about medical practitioners, maybe you should say the doctor, you use the pronoun she. Instead of he's a good doctor, say she's a good doctor, she's going to do digital rectum examination and so forth.
First of all, unfortunately, there are very few urologists, female urologists.
Really?
Yes, there tend to be very few. I don't know why. Secondly, though there are more gynecologists who are male, for obvious reasons, but that said, believe me, I've come to men tend to avoid women when it comes to issues to do with their sexuality. It's an ego thing. You don't want to go and expose yourself, your weakness to a female. Because especially if you go and find the urologist who was the stimulating reason why you were going to see, from what I can hear you say, then she tells you that you're completely useless, then you are in big problems.
Yeah, not good. Mr. Petten, go ahead, please. Ask the doc your question.
Thank you very much. I had two questions, although the other one has been partially answered. The first one, which has been partially answered, I wanted to find out if we have specialized the doctors in terms of the type of cancer, the prostate cancer. I've heard him talk about urologists.
Okay.
And then the second question, I wanted to find out how equipped is the Ministry of Health in terms of having these doctors in almost all parts of Zambia. Remember, we have about 116 districts in the country and the sub-districts. Do we find these doctors all over the country, or we still need to travel to Lusaka, Kabwe, and Chipata for such treatments?
Okay. The second question truly is not mine, that's a policy thing, but I'll answer it. But let me finish, let me do the easier one. Once you do with the urologist and they've diagnosed you to have cancer, treatment of cancer now goes to, I'm a nuclear medicine specialist, so I deal with the diagnostic aspect of such conditions and the function. On the therapy side, the people who deal with cancer are called oncologists. So once the diagnosis is found, the urologist will then refer you to an oncologist. Okay. So coming back to the second question, in the sense of urologists, surgeons, we have increased the training of surgeons. Most surgeons, general surgeons, are found all over in every province, every general hospital. When I say general, it means any teaching hospital would definitely supposed to have a full quota of specialists. We also resolved at the management level in the Ministry of Health, I was part of that committee that used to do that we should also have all general specialists in every province and every general hospital. District hospital might have a different rate, but at least you should be able to have, as numbers increasing, we are treating down the different places, and then eventually to the lower, probably not find the next, but in the hospitals, you probably will find a surgeon. You're bound to find who will have definitely connected to a urologist, but in surgery, general surgery training, you spend a good 6 months training on urology. I have not even done surgery. I know all these things. I also went through it just as a GP in my GP training. So wherever there is a doctor, you should definitely be able to have a workout on the prostate. And it's because we have we're in a field of specialization now, we proceed to refer you to the line specialist. Where there's no line specialist, a GP will be able to do all these investigations. They know already this. They will recommend all these investigations, come up with the answers, and proceed. If they can't do a biopsy, they'll refer you to a surgeon. Even a general surgeon will be able to take a biopsy for you. It does not require you to be a neurosurgeon. So in that sense, you don't need to come to Lusaka for treatment of, for a diagnosis of prostatic cancer. Where the problem is in the treatment. After the cancer is diagnosed, right now, because we have only one referral hospital for cancer diseases, which is in UTH, after it's diagnosed, you end up being referred to Cancer Disease Hospital for treatment. I am mindful of the fact that we are about to set up this funding that's even limited on the Copper Belt in Dola, or is it Quito? We're about to set up another Cancer Diseases Hospital to address the needs. If you've noticed with time, we've had an increase in teaching hospitals. Almost, I think we had very few general hospitals. Now we have more central hospitals and more teaching hospitals. But what that means that we're increasing, specialists are going to the various hospitals. So you do not need to panic. As long as there is a doctor, even a general practitioner in a hospital, they should be able to do a workout and get a diagnosis for you. It is when it comes to treatment that now you proceed to Cancer Disease Hospital if the diagnosis is cancer. If it is not cancer and it's just inflammation, antibiotics can be started at the local site where you are seen. And if you are not responding adequately after the initial course or repeat course, the general practitioner will then send you to either a surgeon or the neurosurgeon now to address the need as arises. But you can hear even the evangelist, he was showing off that he treats people with benign prostatic hypertrophy. So it shouldn't be a big problem right now having this addressed. It's only when it comes to cancer treatment that now you have to go into more specialization, and that usually inevitably ends with you coming to UTH, Cancer Disease Hospital.
Okay, thank you, Doc. We have a few more questions here. We'll start with Big Mose had a question, and then Moses Kambwamba, you'll be next. Mose, please go ahead.
How do you know that the doctor is not just exaggerating the problem because he wants you to be a profit center? Why I'm saying this is like a GP in South Africa told me my PSA was a little bit high, and they went and saw the urologist, did all the tests, and said, well, I think everything seems okay, you can come back after 6 months. I went back after 6 months, and still he wasn't so concerned, and just gave me some medication. And then I had a little bit of
by the way,
some discomfort.
Sorry to ask to interrupt. What medication were you given?
I can't remember. It was about 2 years ago. And then I relocated back to Zambia, and I decided to still, I went to Lancet to do the PSA test, and I think it was like 4.2. And then I went to see a urologist, and he told me my prostate is 5 times large. First, he told me 5 times large, and I went to do some tests, and I found it was 4.2. So 5 times large and 4.2 really is an exaggeration. So how do you tell that the doctor is really exaggerating, like in this case? This is a Forest Park, by the way, where the Egyptian doctor told me my prostate is 5 times larger, which I found I was alarmed and went and did the test, and I found that 4.2 is not 5 times larger.
Is that all?
Yes.
Okay. First of all, ethically, I'm not supposed to comment on what others do, but as one of the senior doctors who even Health Professional Council of Zambia utilizes as a resource person, I'll generally say that problem you talk about, which is to me professional mischief, usually tends to result in the private sector more than in the public sector. Secondly, I'll say most of the specialists are found in the public sector than in the private sector. Even those who tend to go in this private sector, especially in Zambia, usually if you inquire properly, you find that the bulk of them are found in UTH or one of the public sector institutions. They just go and do private practice in those areas. If it is unfortunate, that's occasionally, but very rare. Occasionally, some people do it to make money. For instance, that's why I was asking what medication, if they were finding it to be normal, what medication were they giving you? Because the way you were handled initially, there was no mischief in what was done. It's better to play safe. Prostate cancer is very aggressive. It's better to play safe and be thorough and know that everything is okay and it's not there than not to. But
I can actually answer, like at Forest Park, I was given Benfin 5.
Okay, what is Benfin 5? That's the trade name. So sorry, unfortunately. You don't know the trade name.
Trade name, well, is I don't know. But
whatever it is, you've got a printout, or you've got a cover, a leaflet on that.
Yes, I have. In fact, I can show you the picture.
You can take a picture of it, inbox me, then we can have a discussion of that. I will know what it is. But that said, remember, that's why I was saying that it is okay. All right. Okay, I will look at this later. But that said, I will tell you that the importance of this discussion we're having here is that you know what it is, what the symptoms are, what it implies, so that you also have some basic knowledge to it and why you're doing it. Now, there's no relationship per se, direct relationship between the size of the prostate size with the disease access, the disease entity per se. Remember, benign prostatic enlargement. As you grow, all of us, our prostates keep growing. The problem is when now a normal PSA level begins to rise. Like for you, I had a value of 4.2. That was just minimally raised. Remember, having a 0.2 increase is within normal range of accuracy, of error. We worry now when you find that your levels are at 10. They used to be, that's why you need to have a serial follow-up. You used to have levels that are 2. Suddenly, after 6 months, it's 4. You go after another 6 months, it is 6. Now, that is the warning sign. Something is changing in you. But if you go, it keeps ranging between 2 and 4, 2 and 4, 2 and 4. We are happy. You keep it that way. When you do an ultrasound scan, by the way, they'll calculate the dimensions and give you the volume. What that tells you is just that, like I said, it will give you a volume and you can estimate the mass. The mass is up to 30 grams. But remember, as you grow, your prostate progesterone levels reduce. The body's response to reduction in something that's essential for it is to grow, to increase tissue so that it can produce sufficient levels of the hormone. So its growth in itself just means that you've got benign enlargement of the prostate. Now the question is it symptomatic or non-symptomatic? From what you're telling me, yours was asymptomatic. I didn't hear you mention any symptoms, unless you just didn't mention it. So if it's asymptomatic and you have got enlarging prostate, we just observe it and follow up with those events. If you remember, a second opinion is entitlement. If you go and see a clinician, you ask for a second opinion and they take offense, something is wrong with that person. In medicine, there's no God to medicine. You're entitled, it's your right to get a second opinion, but you find that maybe people are a bit funny, especially these high cost, high value hospitals. And here I speak with caution. Remember, they have to meet their bills. So if you go and see him, you'll find that you've got benign disease, he's asking for a prostate MRI. Be suspicious. Have you found cancer? Because the role of MRI is when you suspect that there's a cancerous lesion and you want to stage the disease. So if someone finds just benign growth and he thinks it's nice and normal, benign, it's smooth and everything, and then he starts talking, your PSA levels are within normal range and says, can I have MRI? Now mischief begins to play. You can't prove it, but be suspicious. Those are the people who say, okay, I don't have money, I'll come, let me find out where, give me a request form, I'll go and book some, I know somebody again, and then you go and seek a second opinion. I think that's the tactful and best way to handle it. Unfortunately, that is very rare. In today's, those you remember, you can sue, eh?
Yes.
There's litigation also, even in Zambia now. If someone mismanages you, misdirects you, you seek litigation. I'm not encouraging it. I'm just having an academic discussion. You saw someone, clinician who does that and is doing it just to make money. If it is proved that they're just doing it to make money, there's a problem.
Nice. Well, thank you, Doc. There was another question from Mr. Kambwambwa. And I also encourage people to put their Penta in the chat so that we can all be connected, and we shall give that list to Dr. Mukamba. So if you really need to see him, you can go and make an appointment to see him.
Thank you.
Yeah, Moses, go ahead. Mm-hmm.
Thank you very much, Professor, and good afternoon, Doc.
Good afternoon to you.
Thank you. Mine is just one question, but maybe it may have A and B. And I'm sorry I joined a bit late. If my question has already been addressed, you just advise that that has been addressed already.
Don't worry, I'll answer you.
All right, thank you. It is on this platform where I think there was a post that was suggesting that the more sexually active somebody is, the more likely they are going to have or to develop the prostate cancer. In that post, it indicated that if somebody is to be healthy with his prostate, he must be able to ejaculate a minimum or an average of 21 times in a month. Later on, there was another posting that was suggesting that. So I seek to be advised or to be educated. Has this sexual activity got a direct effect, or it can cause the prostate cancer, or it can exacerbate the prostate cancer? That's A. Then B is, if one has got cancer in its early stages, the prostate cancer, is it safe to continue being active sexually? Thank you very much, Doc.
Okay. The first point you raise, you see, this is additional research being done of late that has not really been clinically proven to be incorporated in treatment protocols. Until that second article that contradicted the first one, what I had known and what I had read on several fora was that the more active you are, the less the chances of prostate cancer. If you look at my presentation, which will be posted later on, I'm sure, and I'll ask our moderator to allow me, I'll post it immediately after this discussion. You'll go through it. I did not allude to that sexual activity. However, what I can simply say that I did allude to some of the symptomatology that arises due to dysfunction of the prostate that will lead to infertility and impotence. Whether that has any beneficial effect on, if you have prostate cancer or prostate disease, and it is causing sexual dysfunction, you would expect that your sexual drive would be reduced anyway. That's what then the other thing, like I said, this is food for thought and research. Nothing has been cast down as proof. Ideally, medically, it's not yet taken up. There are things that people are looking into and researching into. So I would listen to both of them and take them with a pinch of salt until they can substantiate what they're saying clinically. The second bit was, sorry, just remind me about the second. Prostate, if you have minimal prostate cancer. First of all, Moses, we do not want you to have even one little cell, microscopic cell of prostate cancer, because it is very aggressive and it is a killer. So what we'll do, the moment you find that you have cancer, we will remove it from you. And if it's minimal, it means it is confined to the prostate. We will remove that prostate. The problem with removing the prostate is, remember, the prostate has a sexual and hormonal function. It helps convert testosterone produced in the testicles into dihydrotestosterone, which is the active form, which activates or makes you more sexually active. And without it, you get erectile dysfunction, impotence, and infertility, as I alluded to. So at that point, I will not encourage you to keep the smallest cell of cancer cell so that you can remain sexually active. In fact, that's why we even castrate you even when it's beyond its advanced prostate disease, because the testosterone now will help spread the cancer. So the trick is, let's quickly remove the cancer. If you have any little cancer, as you are saying, it's minimal or confined to the prostate, let's remove that prostate. And let's work at finding ways of increasing your potency sexually. We have Viagra and all these other supplements. If you even go to my home village, even the smallest boy there, the youngest teenager, knows of supplements or roots that will help you become more potent. So the trick is, would rather you alive, hyperfunctioning, than you hyperfunctioning and dying in 2 or 3 years. I hope I've addressed your concerns.
Thank you very much, Doc. It's clear.
Wonderful. Dr. Saili, you had the question.
Thank you very much, Doc. Well, the other question I wanted to ask has been answered, but the second one was on the growth of the prostate. Is there healthy foods that assist not to grow that fast, which you can advise?
I can, yes, the last slide, I've put a link of various foods, various remedies, various stuff that you can take, natural and otherwise, that help with the growth. On the last link, the last slide just before the goodbye, that link. I've attached about 9 to 10 YouTube videos talking just about addressing just that, because naturally, because of my interest in a holistic picture, I looked at the various herbal remedies and alternative remedies that you can take to it and foodstuffs that you could take that help reduce. For instance, tomato is known to reduce the prostate growth and such things. So if you, when the presentation is put on to the blog, take time and open this link and watch as many of those videos as you can in your own time. I am open to discussion with you one-on-one after that. I think my number, you now having, I will not change my profile picture so that you can easily recognize me from the group information, and we can talk further on the site if we need to.
Thank you.
But yes, there are products that help. Yes, I agree.
Okay, any more questions from the floor? Moses, go ahead. Yeah, go ahead.
I think it's an odd hand. I
Okay.
ignore it, please.
Okay. Okay, are there any more questions? I'd also encourage people to put in the chat the penta. Then we shall give that to Dr. Mukamba also. So Doc, as you were talking, I took out my ping pong balls because I play ping pong.
Yes, fantastic. Because commonly, so they talk about walnut. Half of us who probably know what a walnut is, but the ping pong ball,
right.
Yes, that is roughly the size of an adult prostate gland.
This is big. I had no idea.
It is big. It is big.
So how bigger can it even get, given the conditions you're describing?
By volume, it will grow 4 or 5 times. Remember, body's response, there's no uniform way of where human tissue responds. Some people, just like height, some people very tall, others very short. Some people, the same stimulation of hormones can respond to that and anything. But what is important is it symptomatic or not? That's why, if you remember, there was something that was alluded to. In its increasing in size alone is inadequate. As you grow, the prostate grows. It will grow. It starts smaller than that. But when you reach your 4th decade of life, we're talking about something in that size. It doesn't mean that yours will be that size. It could be smaller than that as well. It could even be slightly bigger. You find that sometimes some people, maybe it's double that size, and yet it's not causing any symptoms.
Okay.
So yes, the prostate is quite big.
Wonderful. Well, are there any more questions, gentlemen? If there are no questions, we can wrap the discussion up. But the doc has these slides that he's going to post on the forum, and then the video we're going to. The video takes a while to render, so I'll post the video maybe in a couple hours. But the PowerPoint slides can go up right away.
Okay. All right, I'll post it immediately after this.
Yeah.
Thank you.
Yeah, so Doc, on behalf of St. Paul's community, we'd like to thank you very much for your knowledge and for your generosity of time. This was very informative, and the people that missed out, they really missed out. So hopefully they can watch the video and find you, when they need to find you. And what you said at the very top of the discussion about the holistic nature of your practice, I think is very helpful, because it gives access to everybody. People that are uncomfortable with one thing can go the other side and so forth. And I think that's something that should be encouraged. So I really appreciate that you mentioned that in the presentation.
Thank you.
Yeah, and for gentlemen, thanks for coming. We've got people from across different generations, from the 80s and the 90s. So please feel free to mix. And Mose, don't take 2 years before you see Dr. Saidi. Dr. Saidi is very accessible, so go ahead and reach him.
And take advantage of us, because all this knowledge I've given is for free.
Yes, and on that point, Dr. Mukamba, one
Yeah,
of
we are
our
very
head
good.
boys,
When you come and see me in a private clinic, they'll tell you 800 to see me alone. 1,000.
that is true. Dr. Mukamba, somebody said thank you. His name is Reston Ngosa. You saw his father at St. John's in Woodlands.
Oh, I see.
But he had to leave the meeting early, but he said we should say thank you to you. You were the consultant to his father at St. John's at Woodlands, and he really appreciates what you did for their family. So thank you so much.
Thank you.
Yeah.
And thank you for having me and listening to me. And please, like I say, feel free to chat with me. There are certain things that maybe we might not be able to openly discuss on open fora. We can talk in of the main blog.
That's right.
Don't worry, doctors keep people's secrets. We know many secrets, so we can share it. You are guaranteed it will be a secret.
Yep. Well, thank you so much, gentlemen. And thanks for your time, Doc, and your information, and we really appreciate it. So, yeah, let's go watch some football now.
Yes, true.
Yeah, thank you so
Thank
much.
you.
Bye.
Yeah, bye-bye.
Thank you. Bye, everyone.
Yep, bye, Jason.
I can leave?
Oh, absolutely, yeah. People, they leave at
What?
different times, and this is when
You
they
know what?
to chat.
Oh,
I'm in the meeting.
This one you have come back, Mr. Collins.
He lost power.
Oh,
I
hey,
don't know-
I'm
I
talking
don't know-
about. I'm
I don't
talking
know what's
about
going on
power.
with our man there. He's losing power a lot at his house.
Starting on